of you have heard about OhioRISE because it's a fairly sophisticated audience. I hooked up with them very early when I got the contract. I've met with them regularly, making connections where I can and help. But two things that are connections that I've made. We do our Stepping Up county meetings. We've done 54 first visits. Then we had to switch a lot to Zoom during the pandemic, but it was a blessing in disguise because our team grew from 2 to 9. Many of this room are part of our team, and we co-present with a lot of the locals now on their programs, and it has been amazing the connections that we make. And so the OhioRISE team, the people that are the regionals in that area have been attending those meetings and learning all sorts of connections that are made. And the two coming up, Tuscarawas is May 30th and Jaga is May 25th. If any of you are in those areas and want to participate, it's a 3-hour Zoom meeting chock full of CIT and funding and what the Department of Mental Health is doing and NAMI and you name it. We've got subject matter detail. Let me know, drop your email off at the county and I will make sure you get the agenda, which will come out about a week before the meeting. And so at this point, we're going to have OhioRISE give us a presentation on where they are with their project.
All right, good morning everyone. Thank you, Justice Stratton, for introducing OhioRISE. I'm Kelly Smith. I work with the Department of Medicaid and I'm on the OhioRISE team and I do all of our stakeholder engagement. So I'm here to talk to you about OhioRISE. This is a new program that launched July 1st of last year, and it serves youth with complex behavioral health and multi-system needs. How many of you are familiar with OhioRISE? Great. And how many of you have worked with a youth who's enrolled in the program? Okay, thank you. All right, it's always helpful to know. So OhioRISE has a number of objectives that we're trying to meet. We want to improve the design, delivery, and timeliness of care coordination and supports kids' needs to thrive. One of the ultimate goals of the program is to prevent custody relinquishment and better serve multi-system youth. We've heard many stories over the past several years, actually decades, where youth and families are trying to access costly behavioral health care services, for example, residential treatment services, and they're being told by different systems that they should turn over custody to the state so that they can access those services. And so through the OhioRISE program, we want to prevent that from ever happening. We also want to serve our kids that are involved with multiple systems because we're all serving the same kids. These kids have a behavioral health need, but they also have needs in the developmental disability system, the court system, the child protection system. They might have had a hospital stay. And so how can we make sure that they're getting care coordination across all of these systems? So we want to do that by adding more intensive, in-home, and community-based services and supports. And so these are new Medicaid covered services, and some of them are services that were there, but we've actually enhanced them. Another really important and valuable piece of the OhioRISE program that we wanted to make sure was incorporated into the design and development of it is making sure that families and youth are at the center. And so we're using a national model that maybe many of you are familiar with called High Fidelity Wraparound. So we use that model and its principles to deliver care coordination to youth and families. It really does listen to them. It puts their voice and choices at the center of their care and their treatment. That way they stay more engaged and they have better health outcomes. Since before the launch last year of July 1st, we have been working closely with stakeholders all across the state. We have an advisory council that meets monthly. We have work groups that meet all the time. And we've been really transparent with what the OhioRISE program is all about. They know as much as we do about the program. And we've been very accountable. So even today, as we're very much in the implementation phase and trying to operationalize the program, we get feedback all of the time about the program because we want to make sure that it's working on the ground with hospitals, with the developmental disability system, with the child protection system. So when we get that feedback, we look at policies, we make changes to the program to make sure it's really working. And then we also use a shared governance model. So OhioRISE is a very important initiative to our governor. And so through the Office of Children's Initiatives and all of the state agencies listed here that make up the Family and Children First Cabinet Council, we have really worked to sculpt and mold OhioRISE over the years since the beginning, before we even started the stakeholder work. And we continue to meet with them on an ongoing basis as we develop the services such as psychiatric residential treatment facility, which is coming online later this year. So who is eligible for OhioRISE? These are youth 0 through 20 at the time of enrollment. They have to be Medicaid eligible. They can already have an existing developmental disability waiver, but the key requirement is that they have to have significant and intensive behavioral health treatment needs, which is determined by our assessment tool called the Child and Adolescent Needs and Shrinks, or the CANS assessment tool. A couple of additional ways youth are enrolled into the program is if they have a hospital stay for a behavioral health primary diagnosis, so they're automatically enrolled into the program, or if they have an inpatient stay in a psychiatric residential treatment facility, or a PRTF. Now, these are only out of state today, but we are launching those later this year. So this slide is really all about what OhioRISE is aiming to do about shifting our continuum of care in the behavioral health space. Over on the left-hand side, this is our current state, where we rely a lot on our lower intensity services and our out-of-home placements. We want to shift towards the future state, which will rely less so on those out-of-home placements and really build up some intensive in-community services like care coordination, in-home therapies, and crisis services out in the community. And then, of course, continue to rely on our vital lower intensity services like outpatient counseling and medication management. So when you think about how we're shifting the continuum of care, we did add some new Medicaid covered services, and we also improved some of the services that were already covered by Medicaid by opening the Ohio Administrative Code rules up with stakeholders and getting feedback about how do we build capacity for those services. So we have care coordination. Care coordination is a very valuable tool for families and youth who are involved in all of these multiple systems. This is so that they can get the help that they need to navigate across these systems. Care coordination is either provided by Aetna, the OhioRISE insurance plan, or a care management entity in the young person's community, which Dawn will talk about in a little bit. Once they are determined what kind of care coordination level they need, they're assigned to a care coordinator either at Aetna or their care management entity. And then that care coordinator will help with things like making a care plan to ensure that young person's behavioral health needs are met, helping young people access services and resources, and talking to and providing information to other providers and other community partners, like in the DD system or our child protection system, for example. So we have included in OhioRISE only is an intensive home-based treatment IHBT service. This has been covered in Medicaid since 2018, but again, we reopened that rule and took feedback from stakeholders to improve upon it. IHBT helps stabilize and improve daily behavioral health functioning. We also have, again, I've mentioned that psychiatric residential treatment facilities are something coming online later this year. So we've been working with our shared governance state agencies to make sure that this is something that is useful and beneficial across all of the agencies. This is an inpatient psychiatric level of care for youth in Ohio that are 20 years or younger. This will help keep families together and closer to home, because right now we have about 140 youth on average per day being served out of state in a PRTF. So this way families can access PRTFs here in Ohio, their families can take part in their therapy, and then when they transition back to the home, they can transition back with services wrapped around them easier and faster. We also have behavioral health respite. So this respite is also provided to youth in the OhioRISE program. It's a short-term temporary relief to a child or the youth's primary caregiver in a home or a community-based setting. And then also youth in the program have access to flexible dollars. These are $1,500 and a 365-day period to purchase services or items that address a need or for a child in their service plan. And these are things that aren't typically covered by the Medicaid program. So some of the things that have to be met would be for them to access this funding would be for them to have a reduction in their need for other Medicaid services. It would keep the young person and their families safe and in their homes, or it could help a child or youth be better integrated into their community. So we've seen flexible dollars used for maybe to purchase a new wardrobe when kids are being bullied at school. We've seen flexible dollars actually buy a pet to help that child with their behavioral health needs. We've also seen when a child wants to join a baseball league, it could help pay for a bat or a mitt or registration fees. So things like that have really been helpful. And then what might resonate a lot with this group is a new crisis service that is covered by Medicaid called Mobile Response Stabilization Service, or MRSS. So this is when a crisis situation is happening with a youth and a family in the community, and the family is thinking about calling law enforcement or taking their child to the hospital. Instead, they could call the MRSS hotline and get connected to a team that would come out and de-escalate the situation and start wrapping services and supports around that youth and family and linking them to more services. It's not available in every county yet. It's been grant funded in the past, but now it's Medicaid reimbursable, and we're still trying to grow capacity for that service around the state. And because of conversations through the OhioRISE program, it's not just an OhioRISE benefit, it's actually covered by Medicaid for all kids in the Medicaid program. And now I'm going to turn it over to Dawn to talk about care management entities.
Thanks, Kelly. Thanks for the opportunity to speak with you all today. So I just want to take a minute to set the stage a little bit to talk about, I know Kelly mentioned how kids are, the OhioRISE program is really focused on putting kids and families at the center of services. And what we've seen so many times is for families having to like go over here, especially our multisystem kids have to go over here for one service and then over here for another service. And so to be able to wrap around them is really important. So, and when you think about our care management entities or CMEs, those are the locus of accountability and the center core place for families to go to for coordinating their services. And so if you think about a parent or a family who is trying to get all the services that they need, and if you think about, since this is a juvenile justice subcommittee and we've got kids who are involved in the juvenile justice system, think about that first time that parent and that child has to go to court. I know as a social worker by trade that I get nervous when I have to go to court for a child. So imagine that parent or that grandparent that is raising that child who has to go into those situations. So the care coordinators are really those people who are working with those families to help prepare them for all of those experiences that they're going to have. And so I've got like 4 slides here that talk about exactly what they're designed to do. So we have 3 different tiers of care coordination in OhioRISE. And so our highest tiers are intensive care coordination and moderate care coordination. And those tiers of care coordination are with our CMEs that are across the state. And again, we call those care management entities. And those are behavioral health providers that are across the state, and they're broken down into 20 different catchment areas. And I'm going to show you a map in just a minute. So Kelly mentioned the use of high fidelity wraparound model. And so we use that in our highest tier of care coordination. And that's to focus on those kids with the highest need and the greatest challenges. And so there's more frequency. They meet with those families at least 4 times in a month, and that's usually once a week, and they call and meet with those families every week and call them every week, and they're planning and customizing what services they need and developing care plans for them. And that moderate care coordination is using wraparound informed principles, and they're meeting with them less often, but still at a pretty intensive level. And then that limited care coordination is going to be provided through the OhioRISE plan, which is Aetna Better Health of Ohio. And so there's a lot of reasons why families may have one level of care coordination versus another. So a family may have other intensive behavioral health services in the home that They have somebody coming in the home pretty frequently, so they may decide to have a lower level of care coordination because there's, you can get over a little bit of fatigue with so many people coming into your house all the time. So, but one of the really important pieces of the care coordination is the development of the child and family team. And so it's that child and family team that is developed with the child and family that are going to make those decisions together about what kind of services are going to best help the family, who needs to be a part of that team, and where they going to go for their services. And so that care coordinator helps to pull that team together and get them together for those meetings so that the family isn't doing all that coordination and going here and going here and going here and preparing the family for all of those things. So here is a visual. We have 20 different CMEs across the state. And this just gives you, I like the visual breakdown of it, and it just gives you the name of the providers and then also the counties that they serve on the right side, and then the visual of the map. And then this is just another visual to give you some actual direct emails and contact numbers for the different CME providers across the state. And what I will say too that I don't think is in the slide is that they work very closely with the clinical team at ODM and the clinical team at Aetna, and then our Behavioral Health Center of Excellence through Case Western Reserve around the quality measures and the principles of high fidelity RAP to make sure that the care coordination is being provided in a way that it's supposed to be. So just a couple of other things I will say about the care coordination. It is probably one of the biggest pieces of OhioRISE that's been implemented so far. I think of, I know Kelly talked about all of the other services that are being built up, and I think of this as one of the major legs of the stool, with our IHB, intensive home-based treatment, and our MRSS services being the other two major legs of the stool. And those are services that we are still working to build up. So our care coordination is all across the state, and it's being delivered consistently in a way that looks the same or pretty much the same everywhere. It might look a little different depending on, whether you're an urban area or a rural area, and really trying to meet the needs of those communities. But for the most part, the way it is delivered is the same across the state. And then those IHBT services and MRSS services are services that we are still working to build up for all of our kids in OhioRISE. And this is just another more of a summary slide, just so that you have information about how to make referrals to OhioRISE and for our CANS assessments. So our CANS assessment is as Kelly mentioned, how you initiate a referral into the OhioRISE program, that or through an inpatient stay, acute inpatient stay with a behavioral health diagnosis. That is the second pathway. So just a few metrics that I think are really interesting. So we thought it was really important as we were launching the program to make sure that we had plenty of CANS assessors, since that was the pathway into OhioRISE, to be able to have as many CANS assessors as we could get, because we didn't want that to be a barrier to eligibility and getting into the program. So probably a year before we started the program, we started training folks on the CANS so that they could start doing those assessments. And we use it in a lot of other spaces. I know that the qualified individuals for the purposes of QRTP placements for residential kids, that is also a space where the CANS is used. So to date, we have 2,615 CANS assessors across the state. and we have 20,666 kids that have been enrolled into the OhioRISE program, and we see more and more every day. I would say right now what we are trending is about 40% of our kids are being enrolled through inpatient stays. So we know that there are kids out there that we are still trying to identify through those CANS assessments and getting those CANS assessments completed so that they're getting enrolled before they need that inpatient stay. We would really prefer to get them into the program before they have that mental health crisis. And I think another interesting statistic, especially for this group, is that what the CANS assessments are telling us is that about 36% of kids that are getting assessed through the CANS have some sort of legal need. So about 14% have a history or a possible need. About 14% have a need that's impacting functioning, and then 8% have a need that is dangerous or disabling. My little squares are very tiny, so I hope that I read those right. They're really small on my screen. So anyway, I think that's really important, and this is not, this is juvenile justice, not just kids court involved through PCSAs or something like that. This is specifically juvenile justice involved. So I do want to share a specific court-related success story, and I am going to read this just so I don't miss any of the good parts. So this was a care coordinator at one of the CMEs, or care management entities, taking initiative to get a court-involved teen away from a controlling situation. So she was an older teen who was struggling with some family dynamics. This young person had a step parent who was isolating her from the rest of the family and service providers. This teen was on probation after being charged with domestic violence during a family-based altercation. There was court involvement that led to juvenile court mandating a placement in a crisis stabilization bed, and then an assignment of a guardian ad litem, or GAL. And then to the step parent's dissatisfaction, the youth's assigned care coordinator got in contact with the GAL to begin properly coordinating services, as the CME and care coordinators are supposed to do. And through that collaboration, it was discovered that the step parent had applied to obtain guardianship of the member, and apparent further isolation from any supports or independence. And then the judge on that case found out about it and prevented the abusive step parent from being able to do that. And then after the stabilization, the youth was released and went to stay with their grandparents. Immediately got enrolled in high school, and immediately had a turnaround in grades, straight A's, and then is now interested in studying engineering in college, and is doing really well. And she's now connected to community supports and individual counseling, and really getting a lot of the services that were needed for this youth that they weren't getting before. So, you know, it's that really digging in and really understanding what's happening and what's going on, and they were able to do that for this young person. And I could tell like 10 other stories, but I know we don't have time to do that. But I really do think that there's the creativity that happens with the care coordination, especially while we're building some of these other services that we may not be able to have in every community yet, has really been impactful, and I've seen that. So how does OhioRISE support youth that's involved in multiple systems? All of these services that I've talked about, they're now Medicaid billable services, which Kelly talked a little bit about. Some of them we're still building up across the state. The care coordination is consistent across the state. It creates opportunities for flexibility and creativity. The services and supports are community-based. That's really important. Keeping kids close to home, as close to home as possible, is really, really important. We send about 130 kids at any given point out of state for services. We need to get those kids back to Ohio as quickly as we can. That's not going to happen overnight, but it is a goal of OhioRISE for sure. And OhioRISE care coordination builds a system of care for youth with multisystem needs, and that's part of that shared governance piece. So we are, our CMEs tell us where services don't exist, and that's really important for us and our partners with here at Medicaid and our partners at the Department of Mental Health and all of our other sister state agencies, ODJFS, to work together to figure out how we support building those services in the community. And what are we aiming to do? Reduce custody relinquishment for kids, keep families together, reduce hospitalizations, reduce out of home and out of state placements, like I've already said, and to increase school attendance and performance. So these are all of the things that we're working to do, and that's what we do every day. And I forgot, I didn't even mention who I was. I'm Dawn Pooster, and I also work at Medicaid. And I should have said that at the beginning. I'm the Deputy Director of the OhioRISE program with Medicaid. So thank you all for your time today.